Good afternoon, everyone. We really appreciate everybody joining us for part one of our 9-part educational series, where we've essentially invited all of the subject matter experts for various different populations that we care for in Contra Costa County to come and go ahead and present on the various programs and services that are under the purview of their organizations. And today, for this part one focus, we're going to be focusing on behavioral health services and substance use disorder services. Okay, so first speaker that we're going to go ahead and hop into, we are going to go ahead and talk about our Contra Costa County Behavioral Health Access Line and what can be accessed through this number and the services included. Okay, so I'll go ahead and hand that off.
Asia, hi, my name is Amber Giles. I am the program manager of the Mental Health Access Line. As you know, the Access Line is one of the main entry points to our system of care for both mental health and alcohol and other drug services. Can be accessed via the 888-678-7277 phone number that was displayed on the slide previously. A lot of these slides will have a lot of information, so, and I'm sure a lot of you guys are familiar with it, so I will do my best to summarize and just hone in on the main points. But again, we are a 24-hour available line for both mental health and alcohol and other drug services, entry point to the system of care. So again, lots of information, but essentially what the Access Line does, our primary purpose is one, be a warm, welcoming voice on the other line when folks are calling in seeking help and services and information. Both our mental health clinicians and our alcohol and other drug counselors will complete a screening. For mental health, our clinicians and specialists use the DHCS screening tool. It's a standardized screening tool to determine level of care. And our alcohol and other drug counselors use the BQIP screening, again, another standardized screening to determine level of care to refer. We are also confirming and looking at Medi-Cal coverage and eligibility to ensure that the Medi-Cal is in good standing and status. Our referrals are going to be either verbal referrals over the phone, or we are actually scheduling formal appointments with substance use disorder treatment programs and or the county mental health clinics. Also, in addition, we're receiving incoming calls from anyone and everyone in the community. So we're also providing any information or resources as well, or what's being requested. Who's eligible for services? Residents of Contra Costa County who are either Medi-Cal eligible or who have active Medi-Cal. Our team works really closely with our behavioral health financial counselor team to assist clients if there's any issues with their Medi-Cal, if their Medi-Cal has lapsed, or if they need to transfer their Medi-Cal from a different county to ours. Maybe they have expired private insurance. So any Medi-Cal hiccups or snags, we try to catch those on the front end to ensure it doesn't pose as a barrier for the client to access services in the near future. What to expect when calling and when we're available. Again, we are a 24/7 line, so anytime someone calls our 888 number, they will speak to a live person. Our internally staffed access line with county employees and for appointment scheduling and screening, that's Monday through Friday, 8 a.m. to 10 p.m. for mental health and 8 a.m. to 5 p.m. for alcohol and other drug services. Now we have up to 8 Spanish-speaking staff between mental health staff, clerical staff, and AOD counselors. So we're meeting folks with their native primary language. We're also utilizing interpreter services for any other languages that we cannot accommodate in native language. Again, 24-hour availability. And then lastly, in regards to staffing, I spoke to it a little bit ago, but we have a variety of staff here helping to support the high needs, the high volume call center that we hold. On our mental health side, we have licensed therapists and social workers as mental health clinical specialists. We have mental health specialists who are bachelor's level individuals. We have 1 community support worker with lived experience accessing behavioral health services in the county. And then also a team of substance use counselors, all completing our screening and referral process. That's the overview of the access line specifically, and then I'll pass to Katie to highlight our available mental health services in the county.
Thanks so much, Amber, and thank you for having us. We're happy to present, and this might be overview for many of you. So we just really want to give a high level and then make sure that you leave with the information, questions answered. So I think we will have time for that as well. But feel free to. I'll really turn it over, to Peja and team on the flow of this, but feel free to ask questions as they come up. So Amber talked a bit about the access line, and now we'll focus a little bit more on services, both specialty mental health and non-specialty mental health. So I'll focus on the mental health side because I think Fatima is going to talk a little bit about the alcohol and drug side. But essentially, when you call the access line for mental health, there's a standardized state screening. So all counties are using the same screening. We cannot vary from that screening, but we do have both licensed and license eligible clinicians. And so, if there are clinical concerns that come up or risk, they are able to handle those. So the screening is going to determine which delivery system that the client can access for further assessment. And so you might have heard it called non-specialty mental health. That's basically the clients who fall in the mild to moderate impairment range. And those will be referred to the managed care plans. In our county, primarily it's CCHP, but there are some folks that have Kaiser. So if they're mild to moderate and they have Kaiser, we refer over to Kaiser. If they fall in the severe range, or sometimes for kids, it might be in the moderate to severe range, they'll be referred to the mental health plan, which will provide specialty mental health services. On the non-specialty side, so this is the mild to moderate, there's a variety of services. Primarily at the access line, we're going to be referring for individual or sometimes family therapy, or sometimes medication management. And we partner with CCHP, so we have a shared network of licensed providers, and they are in the community. So on the side that we, on the behavioral health side, oversee, we have about 188 contracted providers. And of those, I think we have about 43 who speak languages other than English, and about 23 Spanish speakers. So they don't always have availability, but we do have quite a vast network. And then with CCHP, they also have contracted providers. Many of those are doing telehealth, but they also have in person as well. And then let's see here. Okay. And there was on the last slide also, I think I jumped ahead a little bit, but there's also, you're probably familiar with the behaviorists that are embedded in the ambulatory care clinics. And so that's more typically short-term therapy, or they might be partnering with a psychiatrist or being referring over for med management. Okay, now for the specialty mental health. So quite an array of services. And again, that's going to be dependent on the client's impairment and their needs and what the treatment team feels. Typically, they're going to be assessed and then receive a combination of therapy, might be case management, sometimes medication management. There's other services as well. There's money management, and we'll get a little bit more into full service partnership, or FSP. And then for children's, it might include therapeutic behavioral health services, which is a little bit more intensive, or sometimes wraparound. Typically, they're referred to one of our regional clinics. So we have 3 clinics for adults and then 3 for children, but we also have programs throughout the county. Like you're probably familiar with the transition team and forensic mental health and so forth. So as it stands, full service partnership is, for outpatient, it's probably our most intensive level of care for outpatient. And this will be expanding quite a bit under Prop 1, which voters passed last spring. There's a behavioral health transformation. And so part of these evidence-based practices like FSP will be expanding quite a bit within specialty mental health. So you can anticipate that this will be more widely available than it is now. But currently we have, I believe, 7 CBOs that are providing FSP. And then also currently our Central County Adult Mental Health Clinic provides FSP. Again, this will be expanding quite a bit in the future. Referrals typically will go through, if they're connected to our clinics, it's usually the treating provider, working with the manager to make those referrals. So that might be you reaching out and coordinating with those care providers. Let's see here. Okay. And then crisis residential. So we have Hope House, which is next to PES. And it's a short-term, often around 2-week crisis residential placement for adults. They have 24-hour staffing. They have counselors, psychiatrists on staff. And it's really for that kind of intermediate, often when a member's stepping down, not quite ready to go home, or maybe they don't have a home at the time. And so it's just really to help with that, to avoid that readmission. And typically referrals will come from inpatient facilities or sometimes our psychiatric emergency center. And referrals can come from the community, but only if the client is already open to one of our regional mental health clinics. I'm not going to spend much time on crisis support services because Amanda will be presenting on A3. You're all very familiar with PES and the Youth Stabilization Unit. So this is more just high level, going through the more acute stabilization services. Okay, and I will turn it over to Fatima.
Thank you, Katie and Amber. Good afternoon, everybody. Thanks for inviting us. My name is Fatima Matasol. I'm the program chief for alcohol and drug programs in Contra Costa. And with me today is Steve McNutt, where we will both be presenting on substance use services. He is a substance abuse program manager, and he also happens to be an ECM provider, like many of you. And with that, let's go to the next slide, please. So a little bit of an overview. I'm gonna talk a little bit about the Memorandum of Understanding. We'll talk, of course, about substance use disorder services. And I'll probably go through quickly through accessing services because both Katie and Amber did a phenomenal job at explaining how people can access our services. So Alcohol and Drug Services administers the Drug Medical Organized Delivery System. For short, we call it the DMC-ODS. This is considered an inpatient, prepaid inpatient health plan that operates as a managed care plan, very much so like Contra Costa Health Plan. The DMC-ODS is subject to the Centers for Medicare and Medicaid Services, CMS, and state Medicaid agencies, SMAs, which do the oversight to ensure that there is accountability and compliance with required quality and program integrity safeguard requirements for network adequacy and service delivery. Again, very much so like a CCHP. The DMC-ODS is a carve-out to provide specialized services for medical beneficiaries with a substance use disorder. So in other words, when it comes to substance use, everybody who has a medical from Contra Costa has diagnosed with substance use, they need to be referred through us because we would be the ones providing that type of services. The behavioral health plan includes both the DMC-ODS and the mental health plan, which was described by Katie. So the manner in which the services are delivered are governed by this Memorandum of Understanding that exists between CCHP and the behavioral health plan. And remember, behavioral health plan includes both the DMC ODS and the mental health plan. And how we communicate, how we track clients, how we do follow-ups on clients that may be referred by CCHP to us, is all governed and outlined in this MOU. Next slide, please. Behavioral health substance use services include withdrawal management, outpatient services, residential program, specialized services, and medication-assisted treatment. Katie and Amber both covered that in order for people to access services, they go through the access line. They also covered the fact that people get a brief screening and then a warm handoff to a treatment provider with an appointment. Clients get or members receive a screening, but when they go to their first intake appointment, they will get a full assessment to ensure that there is no discrepancy between the referral, the screening done by Access, and the admission or the assessment done at the treatment program. This could mean that the person is transferred back to the appropriate level of care. I would say that we have a 98% rate of accuracy between the screening done by the Access line and the assessment done by the provider. Something that's very important and unique and very different than the mental health plan is that 98% of our services are contracted through community-based organizations. In other words, we manage and administer contracts. We do very, very little direct service delivery. Next slide. And at this point, I will transfer to Steve McNatt so that he covers the rest of the services.
Thank you, Fatima, and thank you, Amber and Katie. I'm going to reiterate, I think it's been mentioned a few times that, there's a single way of accessing these services by contacting our Access line. There is, a few exceptions. One of those is withdrawal management. You are able to contact these facilities directly to place a client in withdrawal management, but you can also call the Access line. That's still a reasonable place to contact. A typical stay at a withdrawal management facility, also known as detox, is 3 to 5 days, but that can be extended depending on medical necessity. Clients are given individual care management that include referrals to other levels of care. Clients are also encouraged to attend programming, but it really depends on their symptoms. In the first couple of days of treatment, they're going to be getting rest. So it's, if they feel, good enough to attend treatment, they will. They receive information about medication for alcohol disorders, and these are social model detoxification programs. We do not have medical model programs at this point, but the programs are located in Concord at Pueblos del Sol, the Richmond Health and Wellness Center in Richmond, and then there's also women centers at the Oz Center in Concord and East County Wallem in Pittsburgh. And then again, you just contact the Access line to access those services. And then once that screening takes place at the Access line, there's different levels of care. One of those being basic outpatient programs. There's also intensive outpatient programs. Intensive generally is 9 to 19 hours per week for adults, 6 to 9 hours for adolescents. There's individual and group sessions. They attend, it's all evidence-based programming. There's co-ed programs available as well as telehealth. There's 12 outpatient facilities offering intensive and regular outpatient services in our county. And there's substance abuse counselors embedded in all of our mental health clinics throughout the county, including our youth clinics. And so, with ECM, as we provide services to the children and the adolescents, there are outpatient programs for them at our mental health clinics, which is great. And there's also outpatient services for Spanish-speaking only clients that are located in our West and East County Family Justice Centers. And those are offered at the evening hours during the week. And then we got residential treatment programs. The average stay in residential treatment is about 45 days. It's based on medical necessity. As Fatima mentioned, there is an initial screening at access, and then a full assessment takes place in the program, and not just at the initial intake, but throughout their stay, to really have a good idea of what level of care they need to be at any given time. And so at any given time, that warm handoff can take place between residential treatment and intensive outpatient, or vice versa. They may be an intensive outpatient and then all of a sudden need a higher level of care. So that's always being assessed for throughout their stay. All the treatment programs are staffed by substance use disorder counselors, which includes the licensed therapists on staff, and all programs have a medical director. There's 9 licensed residential facilities throughout the county. In fact, one that's county operated, Discovery House, is a county operated residential facility that's located right here in Pacheco. They're gender specific. There's 4 serving women, 5 serving men. Facilities range in size from 8 to 40 beds. And are located in all 3 regions of the county. And then there's the one men's program that's dedicated to Spanish speakers, and that's in the same facility as Pueblos del Sol, which is one of the detox centers. It's co-located there is a residential treatment program. And then there are also some women facilities that offer perinatal services and beds for small children. So women that are pregnant or maybe just had a small child, there's residential treatment options for them as well. And then finally, medication-assisted treatment. In my opinion, I think, Fatima and Dr. Sapphire, I think they're pioneers when it comes to our medication-assisted treatment programs in our county. Choosing Change has been around a long time, even before it became sort of a best practice. Medication-assisted treatment can be used as a standalone treatment or in conjunction with outpatient and or residential treatment. We have our Choosing Change departments that have really grown immensely over the years. We have classes in all regions of the county at all hours, day and night, and it's really become a robust program. But we also have the BART clinics and also Harmonic Solutions. There's other providers that provide these medications based on clients' current substance use and their current living conditions. These are for beneficiaries with opioid use disorders. They do have a choice between methadone and buprenorphine. So Choosing Change would be a good option for somebody that's receiving buprenorphine, but you have the BART clinics for methadone. Methadone is distributed daily at daily office visits until take-home doses are suitable. Buprenorphine can be prescribed as any prescription, and it's picked up at your local pharmacy. Sublocade, which is the injectable version of Suboxone, they can work with counselors can work with a person's primary care physician if that's something that's more suitable for a particular client. And then there's also medication for alcohol use disorders that can be prescribed through PCP or a program called Recover. There's 3 methadone buprenorphine programs located in West, East, and Central County. And then, like I mentioned, buprenorphine is also available at all of our Choosing Change clinics, and it can be prescribed by any primary care physician. And then Recover is a program that is offered via telehealth. And then these are some additional substance use disorder services. One is recovery residences. A lot of folks term these residences sober living environments, but the county has contracted out with providers that specialize in running these types of homes. These are for individuals committed to abstaining from drug and alcohol use. One of the providers, Oxford House, run these houses across the nation. They've been very successful at running these recovery style homes. They're not licensed, but they're monitored very closely by AODS. These houses are peer-run. Clients require to enroll in outpatient treatment during their duration or their stay at these recovery residences, and they actively participate in the house. I think we started, or Fatima, correct me if I'm wrong, you started with what, about a number of houses now? Now there's just growing throughout the county. And then you also have recovery support services, which is wonderful. Our ECM team work very closely at times with the recovery support workers. They provide individual and group counseling. Recovery coaching and monitoring are delivered in person via telehealth or by telephone. They're really looking at these clients that may have been in residential treatment programs multiple times, in the past year or the past couple of years, and they really provide an extra layer of support as they're transitioning from one level of care to another. So it's a really, really important service that they're providing. They provide linkages to life, child care supports, employment services, job training, education services, and other services. And like I was saying, our ECM staff, we support those efforts, in any way we can. One of the newer, I guess it's been around for a couple of years, a new service is called Recovery Incentives Contingency Management Program. This is an incentive-based program for stimulant users. It's evidence-based. It's been around for some time. There's been a lot of evaluation at how successful providing incentives could be for someone trying to abstain from stimulants. And so basically, they go to these groups, and if they can abstain from the stimulants for so much time, that they'll receive a gift card, which is not just self-affirmation, but it's a great way to begin the momentum of recovery. And it's like I said, it's an evidence-based program, and they've been providing that in a couple of different, I think it's in 2 regions currently, in East and in West, at the REACH and the UGIMA programs. But yeah, again, it's been a great program. Back to you, Fatima.
Thank you, Steve. This is the most exciting slide for me. In substance use, we do implement a lot of prevention services and programs. We all know that addiction is something that can be inherit, and it could be genetics, and there could be a number of reasons. But one thing we know in the field of substance use is that the disorder can be prevented. And we know that by utilizing a lot of research that we can base these. And there's specific programs that we implement when we determine the application of what's called primary prevention. We utilize the public health approach to address these. We use a lot of education and awareness, information dissemination, youth development and youth leadership. We do a lot of coalition building and also policy and media advocacy, which includes social media. We also implement secondary prevention, which is screening and early intervention and referral, or also known as EPSDT. Secondary prevention, both primary prevention and secondary prevention, are for individuals who do not have a diagnosis of substance use disorder, but that we know we can reverse the early onset if these services are applied at the right time and at the right location. The populations for prevention services and programs include parents and families, young people, middle and high school particularly, and the community at large. Next slide. Thank you. And I'm not going to cover how to access SUD services. I will probably just to recap that the only service that doesn't require going through the access line is medication-assisted treatment or withdrawal management. Also, that residential services need an authorization, but there is nothing that ECM providers need to worry about. Because we have a system in Contra Costa that eliminates and prevents the burden on providers or on the client. Is very streamlined. Providers generally get a pre-authorization, if you will, from the moment they were referred from the access line. And it has been working super well since 2016. So just a quick reminder about that. And with that, I think it's Amanda's turn. Thank you.
Thank you, Fatima. Hi, everyone. Thank you so much for having all of us today. It's a pleasure to be with you and to share about our services. My name is Amanda Dold, and I'm the A3 Crisis Services Program Chief. And I really want to talk with you today about high level what A3 Crisis Services does. And then, of course, if there's time for Q&A for all of us at the end, I'll defer to Chris and Peja. So here are the topics that I'm hoping to cover in my high-level overview of A3 Crisis Services. I really want to share with you what the need is for this type of service. I would like to share with you the history of A3 and our Miles Hall Crisis Call Center. I will talk about the use of our multidisciplinary teams. I will describe our levels of response, and then we'll dive into where we stand today in terms of our hours of operation and staffing, and talk a little bit about some metrics that we're tracking. So let's begin here by talking about the need for mobile crisis services. So Contra Costa County has approximately 1.2 million residents, and of those residents, nearly 200,000 will need mental health services. 1 in 5 individuals experience mental health challenges, and mental health challenges are the third most common reason for a call for an ambulance. Currently, we have over 8,000 visits to psychiatric emergency services every single year. If you think about when somebody has a crisis, whether it's a fire, a crime, a medical emergency, they call 911 with the expectation of getting an immediate emergency response. However, when that emergency is a behavioral health emergency, there was previously no appropriate response for this type of crisis. And A3 addresses this enormous need by making behavioral health part of the emergency response system. We like to consider ourselves the fourth arm of emergency response. So we can't talk about A3 without talking about Miles Hall. Miles was a young man living in Contra Costa County, and he was experiencing behavioral health symptoms for years. His family really tried to get support for him and get services. And he was unfortunately in the midst of a behavioral health crisis when he was killed by law enforcement. He was only 23 years old. He was unarmed and not a danger to anybody, but just was really struggling with his mental health symptoms. His family really used this tragedy to advocate for positive change system-wide. They brought together the partners in the community, so Contra Costa Health, law enforcement jurisdictions across Contra Costa. They brought in AMR, community partners, and really we had this approach of redesigning what was previously known as Mobile Crisis Response Team into what we are today, which is A3, which stands for Anyone, Anywhere, Anytime. So over the course of 2020 through 2022, we really engaged in these rapid improvement events and value stream mapping events to really identify where are the gaps in our system to ensure that this tragedy doesn't happen to other families. Oops. Sorry. There we go. All right. So one of the things that makes A3 really unique is our diverse workforce. So we have a variety of disciplines that work with A3, including interventionists who we have employed through Haluna Health. We have nurses, we have peer support specialists, we have mental health clinicians, and then substance use disorder counselors. We also, over the course of the past couple of years, have developed a really robust leadership team. So we have 2 program chiefs, 1 program manager, 3 mental health program supervisors, 1 substance use program supervisor, and then we also have a project manager, 2 clerks, and an administrative assistant as part of our A3 team. And I'll talk a little bit about our growth in a couple of slides, but this is pretty remarkable given that even a couple of years ago, we had 5 staff. So we've had a lot of growth in the last couple of years, and there's still a lot of growth yet to come for us to be truly operational 24/7 while using only permanent full-time staff. So this graph gives you a sense of the A3 model. So a call can come into our Miles Hall Crisis Call Center really by anyone in Contra Costa County. So oftentimes the caller is a family member who's concerned about their loved one who's in a crisis. More often than not, in the past year, we've been increasing our calls coming directly from law enforcement. So a person who is in crisis calls 911. And because we have developed those relationships with law enforcement, they then direct the call to A3 because we are the more appropriate team to respond to a behavioral health crisis. When that call comes in, we could complete a triage over the phone. And that really is to identify what the nature of the crisis is, to gather some basic demographic information. And then those questions on the triage help us determine our level of response. And we have 3 different levels of response. We then dispatch our team into the community and we meet the client where they are in the crisis. So if they're in their home, we will go to their home. We can go to a homeless encampment, really anywhere where they're experiencing their behavioral health crisis. We will dispatch the team to go out to meet them where they are. We also, during the field visit, we will assess to see if they're meeting criteria for an involuntary psychiatric hold. And if they are, we will place them on that hold and they will be directed back to psych emergency services or the youth stabilization unit for further care. If they are not meeting criteria for a hold, our team will work to help them build a safety plan that can help them avoid a future crisis and also help to get them connected to services. In our near future state, we will have a wellness campus in Concord that will also include a peer respite center and a care on demand center, which will also help folks who don't meet criteria for a hold and do not need to go to psych emergency to go somewhere where they can still receive some care. So when we're responding to a crisis, we have 3 different levels of response. So when we're taking that call into the Miles Hall Crisis Call Center and completing that triage, the questions that we ask help us to inform what the best level of response will be. So all of our field visits, no matter which level, 1, 2, or 3, it always includes a team of at least 2. We never send out individuals on their own. Occasionally, it will be a team of 3 if we have a new staff who is shadowing and learning and going through the onboarding process. So a level 1 would be the lowest acuity field visit. It might be for somebody who is unhoused, has food insecurity, and just needs some linkage to resources. This team is the one team that does not include a clinician because there's not a great chance that the person needs to be placed on an involuntary psychiatric hold. Our level 2 response is actually our most common response. So this team will always include a clinician or a nurse, both who are designated to write those involuntary psychiatric holds. And then it will also include another team member, and it could be a peer support specialist or a substance use counselor. And now that we do have more staffing, we do try to tailor the team appropriately to whatever is being presented. So if somebody is in crisis and also using alcohol or other drugs, we try to send this clinician or nurse out with a substance use counselor. And then our level 3 response is also always a clinician or a nurse, so somebody who can write that involuntary psychiatric hold if needed, and a peer support specialist or a substance use counselor. And this one includes law enforcement. And the reason for the level 3 response is because there is a threat of violence to the team or people who are on scene. There might be a weapon that's part of the presentation of the crisis. So for example, someone may call and say, I'm feeling really suicidal today and I have a gun, it's on the table and I'm prepared to use it. And so we would want to make sure to have law enforcement there present to make sure that the client that's in crisis is safe and that our team is safe as well. Once we meet on scene, we'll do a quick huddle with law enforcement to make sure that we're all on the same page about the plan, and then we'll proceed with the field visit with both law enforcement and A3. Oftentimes, once law enforcement determines that the scene is safe, they will leave and A3 will continue with their assessment. All right, so let's talk about where we stand today. So when we began with our A3 rebranding a couple of years ago, we had limited hours. We were not open on weekends. Then we started to slowly increase our coverage and we added Saturday and Sunday, but it was still sort of standard business hours, 8 to 5. Eventually, in sort of mid 2023, we expanded our hours to go to 12:30 a.m. And then per the state mandate for mobile crisis programs, we were mandated by the end of 2023 to be 24/7. And so on December 1st, 2023, we went to be 24/7, and there's no going back. We are now forever 24/7 operation. Currently, all of our teams are dispatched from Martinez, and a future state is to have regionalized hubs where we can dispatch more quickly. So if a call comes into the Miles Hall Crisis Call Center and the caller or the person in crisis is in Far East County, we would already have a team or two stationed in that part of the county to dispatch quicker. Also, initially, we were only serving adults, but then last July, we began serving youth. So now we serve all ages. I talked about this a little bit earlier, but when we first began our rebrand in 2023, we had 5 employees. We currently have 48 and counting. And even a year ago, we just had 26 permanent full-time employees. So lots of growth. And lots more to come, because to truly be operational 24/7 with just permanent full-time staff, we probably need 50 more positions. And the reason that we're able to be operational 24/7 is because we utilize overtime staff from other parts of our system to help support evenings and weekends. And we really rely heavily on them, and we're so grateful for them. And to be truly operational with just permanent employees, we would probably need 80 permanent full-time staff. All right, let's get into some of the metrics here. So I want to share with you a little bit about our metrics and our data. So we have anecdotally noticed a huge increase in call volume and field visit volume over the last couple of years, but I think that we have a dashboard that also reveals that we've had a lot of increase in call volume even since last year. So in 2024, we had a total call volume of 20,173 calls. In July 2023, we had a total of 830 calls. And then a year later, in July 2024, we had 1,700 calls, which was 108 increase in call volume. For field visits, in all of 2024, we had just over 3,000. In July 2023, we had 70 field visits. And then in July 2024, a year later, we had 367 field visits, which was a 424% increase. So the data is showing what we think we know anecdotally, that we really are getting busier and busier the more that people are aware that our services are available to them. We do have an internal dashboard that gives us this really robust data, but I also want to point you to our external dashboard, which is public facing. And if any of you are interested in the data, you're welcome to check that out. It is real time, and it will give you a sense of where the majority of the calls are coming in from, like which cities, some of the client demographics of the people that we're serving, and our call volume and field visit volume. So here's a graph to show you our crisis calls by city, by quarter, from July 2023 until December 2024. And you can see that the calls are steadily increasing every quarter for every city listed here. We actually have data for every city within Contra Costa County, but these are the cities where we visit the most and receive the most calls for. And Concord is consistently the city where we're doing the most field visits. Oops. So here's the data to share about who is the referring party to A3. So by and large, the majority of the time that we're receiving a call, it's from a loved one who's concerned about their family member who's in crisis. That's about 30% of our call volume. 26% is the person experiencing the crisis themselves. And then 24% of the time is law enforcement punting those calls from 911 over to us, because again, we're the more appropriate team to respond to behavioral health crisis. You might wonder what other could be. Some examples recently are that somebody is shopping at Safeway and they're leaving the store and they notice that somebody looks like they might be in a crisis. They call A3. It could be other community providers calling us. We also do some great coordination with Access Line. They're receiving a ton of calls and they're also not doing crisis, although they are getting those calls sometimes. So they'll punt those to us and then vice versa. Sometimes we get calls that it's not a crisis and instead the person wants to get connected to resources. So we'll give those calls over to Access Line and do a warm handoff. I just want to end here by sharing the vision that we created for A3 when we initiated our redesign nearly 5 years ago. So our aim is to provide timely, appropriate behavioral health crisis services to anyone, anywhere, at any time in Contra Costa County. And that is it for A3, and I'll turn it back over to Peja or Chris.
Thank you, thank you. I really want to say thank you. It's like a wealth of information. I always go ahead and learn something new. Every time we have our behavioral health partners go ahead and come and present. Again, these slides and presentation will end up being posted online in the coming weeks for you all so that you all can go ahead and review them with your team. And I do want to go ahead and highlight our next session 2 training, which is going to have our internal CCHP behavioral health department. That's going to be going over CDE for our autistic kids, and then also FBA and ABA linkage for early intervention, as well as we're going to have somebody come from First 5 to come, in particular Help Me Grow, to go over some of the different services that they also go ahead and offer our youngsters within our community, as well as we are going to have somebody from the regional center to go ahead and come and talk about the variety of different regional center programs and eligibility as well, to go ahead and really go ahead and wrap around our children, which may be having those needs and early interventions. So with that, if there's any additional questions, feel free to go ahead and send them to us. We'll go ahead and put them all together and submit any answers to you all from the behavioral health team, and we'll see you all again on Monday. Have a nice day.